Okay, Stroke by MKSAP 17th edition, which is the newest edition, and it's actually really high yield. And I recommend it for all those that are in residency. So stroke is ischemic or hemorrhagic, also based on time. TIA obviously less than 24 hours. Okay, so prevention of TIA, ischemic stroke, the most important thing of this slide is when to begin warfarin and when you do surgical clipping in case of an aneurysm. Just remember that the type of atrial fibrillation doesn't affect their decision to anticoagulate, and that warfarin is the only approved drug for atrial fibrillation associated with the valvular heart disease. It's really important to know that if a patient with a TIA comes, they need these 4 tests done because they have an increased risk of stroke within the next 48 hours. It's also required that they're admitted if their ABCD2 score is more than or equal to 3. Again, don't be tricked. Important here, if they present with vertigo, they're elderly, vertebrobasilar stroke because that's present near the cerebellum. So RTPA has to be administered within 3 hours of a stroke, but there's exclusion criteria if you're going to administer up to 4.5 hours, and I've even read up to 6 hours. You can do intraarterial. Again, this inclusion criteria, but that's not standard protocol. In patients with suspicious of thrombolysis-induced ICH manifesting as near deterioration, the infusion of RTP should be stopped, and this is determined by repeated neurochecks. Okay, so subarachnoid hemorrhage is less common than ischemic stroke. Just remember that aneurysms and centennial headaches are more common with subarachnoid hemorrhage. It's also less common that you see intracerebral hemorrhage, but most important is to know that they're hypertensive as a risk factor. Okay, so to determine whether it's an ischemic or hemorrhagic, a CT without contrast is going to be used to establish this diagnosis.